speaker is another great surgeon, Mahipal, from Center for Sight. And Mahipal will talk to us on the way he manages his cases.
Thank you very much. I'll be talking about subluxated cataract, and I'll be talking specifically as to how we manage it using the femto laser assisted cataract surgery. Now, as has been said by the earlier speakers, in subluxated cataract, what is the basic aim? The basic aim in this is to preserve the capsular bag and to have minimal vitreous loss, because if you have vitreous loss, it's very difficult to keep the bag in place. And if you have the bag preserved with minimal vitreous loss, you will be able to place the IOL properly, and this would reduce the risk of problems like retinal detachment, glaucoma, iris chafing, etc. Now, what is important is that when you are doing a subluxated cataract, there is the importance of having a clinical assessment so that you are prepared beforehand. And obviously, these are the sign phacodonosis. There is an increase in the intralenticular space. There could be a lens edge that could be seen. And you should also assess in the supine position. Sometimes the patient comes and you don't find it at that time, but on the table you see that. Now, these are the various reasons that obviously you are aware of as to why there could be subluxation, trauma being one of the important things. Now, once you have assessed that there is a subluxation, what you have to do is that you have to assess the extent of subluxation, like to find out what is the etiology of subluxation, because this can define whether it is likely to progress or it's going to be stationary subluxation. And also you have to assess the grade of the cataract. If you assess the grade of the cataract, that can help you plan the surgery. Now, this is normally the dictum that I follow, that if it is a small subluxation less than 3 clock hours, you could either use the 3-piece haptics, not a single piece, but the 3-piece haptics, align it in such a way that there is a pressure on where the subluxation is so that you get a taut capsule, or you just use a CTR. If it is still more, then you possibly would need to do a ring fixation if a CTR is not working. And more than that, if and it's a progressive disease, then you have to definitely go in for the glued IOL, whether the technique as Amar proposed or what you have the Yamane technique, etc. I normally in large subluxations prefer to do the glued IOL. Now, the challenges obviously are that if the subluxation is more, there is the problem of having an intact capsular axis, and that is crucial for you to have. There is an excess in the lens mobility, lens tilt is there, and displacement, and if there is vitreous in the anterior chamber, that makes doing a capsular axis difficult, because there isn't a traction or a counter traction force that you have. If you have a discontinuity in the capsular axis rim, putting in a CTR becomes a relative contraindication, because it will rip it apart and it is going to increase, and you may lose the CTR into the vitreous. The other problem is, because there is a subluxation, you have a space, so there could be a continuous vitreous hydration that happens during phacoemulsification, and this makes the whole thing worse, because the vitreous keeps on coming out, and this leads to more vitreous positive pressure and shallowing of the anterior chamber. So, can we make it easier? So, these are two techniques that I am going to talk about. One is the FLACS, the femto laser assisted cataract, and the second is a vitreous decompensation, which is there. This is a video loaned to me by Dr. Kumar. This was a small pupil, irregular shallow AC. You can see there is a iridotomy that has been done. You can see, I'll just show you, this is a subluxation. Can you see the phacodonosis? You can see this is phacodonosis in this case. It's a shallow AC. What do you do in this particular case? So, basically, go ahead, put a Malugan ring in this particular case. Once the Malugan ring, can you see the subluxation? You see the iris bowing? And this is obviously a bad iris, that is, there is a bad subluxation, there is a phacodonosis as was seen, and you can center the capsular axis, make it larger, and once you have centered, you just press on the catalyst system, and you can see that you get a good capsular axis. That is the biggest advantage that you have with the femto, that irrespective of the subluxation, because it has an OCT image, it will get you a good capsular axis, irrespective of the fact if there is vitreous in the AC, it is still going to get you a good capsular axis, and that is going to be like half the battle won. So, once you have done this particular thing, you have got the nucleotomy also done, then you go ahead. Then you go ahead and do the procedure which is there. Now let's look at the advantages that you have on the femto-assisted cataract surgery. It is not dependent on Zoller counter traction for capsular access and is done in a closed chamber and allows lens fragmentation without any additional stress. Yeah. Well, this is the after the femto, because you have been able to do the capsular access well. The ring is in place. You can see that there is mobility of the nucleus. So what is being used is the hooks. Ideally, capsular hooks should be used, but these are the iris hooks which can still stabilize. And once you have stabilized, so you have a Malugin ring, you have capsular hooks, and you can work and get away the pre-chopped nucleus, as you can see. And there is a second capsular hook that has been an iris hook used as a capsular hook which is there. Once you have done that, you can see that the procedure of surgery becomes relatively easier. You have a stable bag, you have a good capsular access. You have to do a slow motion phacoemulsification. Bimanual IA is therefore recommended. Now putting in a capsular tension ring to get the entire thing in position so that it remains in position. And once you have done that, you put an intraocular lens. So this is something where a femto laser is obviously going to be helpful. Now this is another case of a traumatic subluxation. You can see whenever I have subluxations, I push the patient towards towards femto. Can you see the crumpling of the iris? Can you see the vitreous here? So this is a condition you have to get onto the pupil because there could be falsification. We are just raising the lower end of the femto posterior capsule so that there isn't any problem in that. Once you have that, you can see that we have done a capsulotomy and a good capsular access. Now see, there is this traumatic case. You could, this is the iris atrophy. He had a shuttlecock injury. Can you see this subluxation? Can you see the vitreous coming out here? Advantage again is that you get a great capsular access. Once you have a great capsular access, your half the battle is won. This is the capsular hooks that we are putting in this particular case. You can see this is capsular hook again, gentle hydrodissection which is done, pre-chopped nucleus, so you are able to have a good nucleotomy with the femto, and again slow motion phaco, you are able to remove the pieces of the nucleus, putting in a CTR. You don't need to do, because this is less than 6 clock hours, you don't need to put in a fixation with a suture. A CTR will hold, and now you can again see this is a 3-piece lens that we have. It will again give you more stability. Just putting in tricot, the vitreous which was there right from the beginning, doing a vitrectomy. Once the vitrectomy is done, we go ahead and do SFT again. Amar has kind of described that. Once you have this SFT that is there, you can go ahead and close it. And this patient is doing well. Actually, day one, the patient had a 6/9 vision. Just to see that the vitreous is not there, just put an air bubble. This is the final thing. This is vitreous decompression. So you use the pars plana side to decompress the vitreous, because the hydration of the vitreous causes a problem. Intermittent vitrectomy with moderate cutting and low vacuum is something that is required. So again, you see this is a subluxated cataract. There is vitreous post subluxation. This is 6/9. He was a doctor who came to me from Patna. Phacodonosis, grade 3 cataract. Let's do a femto assisted cataract surgery in this particular case. Again, you can see, I'll just go forward. Again, can you see this vitreous here? This is the vitreous blob. You can see that the iris is falling back. You have to look at both the anterior and the posterior capsule. You can change the widgets, and you can get it onto the anterior and the posterior capsule. Capsulotomy, you can center. So I'm on the scanned capsule, but you can see it's going on the side. The modifications required because it is cutting onto the iris. So we're making it small, but you can see it's still cutting the iris. So what we do is that we move it slightly. See, actually, when you're doing a scanned capsular access, if you have put the ring, the thing is going to move towards a different part. So you really want, so you can see now I am just This is so you have a custom center also that you can do. One is scanned capsule, limbal scanned, you can have pupil center, so you can have all these. This is the Femto procedure that has been done. Once you have the Femto procedure that is done, just see here we are doing the pars plana approach. Here again there is vitreous. We are taking away the fluid from the side. We have done the trocar cannula. You can see this is a vitrectomy. We have put tricot. You see the lens moving towards that area. The capsulotomy again is free flowing. That again, as to re-emphasize, Femto gives you a free floating capsulotomy or a good capsulotomy, irrespective of the amount of subluxation that is there. I'm putting a ring now. Once the ring has been put right in the beginning, you can see that again a pre-chopped nucleus, easy to get it out. And once the nucleus is out, you can go ahead, bimanual irrigation aspiration, keep the chamber deep. Once it is deep, go in with a 3-piece intraocular lens and again go back, do a vitrectomy. So a pars plana approach is also very important, or is a good technique when I feel that the subluxation is too large. Then I want my retina people to help me and do a 3-port availability at that time so that we can have a vitreous decomposition along with it. And then once you cut away the vitreous tags which were there, and that is the end of the surgery, and this is the post-op view of this particular case. So this is what we have. This is Journal of Cataract Surgery. We call it as limited pars plana vitrectomy to optimize the surgical outcomes in subluxated cataracts doing femto laser. So my choice is a femto laser assisted cataract surgery in cases who have subluxation, even if they have some amount of vitreous that is coming in, and usually the results are good. The advantages of this vitreous decompensation is that it prevents further herniation into the anterior chamber, deepens the anterior chamber, creates the adequate space for you to do phacoemulsification, and you use these capsular expansion and fixation devices to keep the whole thing there. So the take-home message in this is that you need to have low fluid settings to prevent surge, tamponade the area of zonular defect with dispersive viscoelastic, do femto laser assisted capsulotomy, and vitreous decompensation through the pars plana route will allow you to do safe phacoemulsification. So friends, difficult situations often yield the best results if you are able to apply technology and the little adaptations of a capsular hook, CTR, or fixation, etc. So that was what I wanted to bring home to you, that Femto is a powerful tool for these cases of subluxation. Thank you very much for your kind attention. Thank you.
Any questions anybody would like to say? So I think what Mahipal has said, that Femto really does assist in complicated cases and tough cases where it does make your life much easier. So I mean, to do a rhexis in a subluxated case and always get it right, and then you can go ahead and put your hooks and further save the case. So I think that no doubt is a right route